Hi everyone, this is Khanlou, your favorite neuropathologist with third series of the Histology of normal skeletal muscle and neuropathology of Duchenne muscular dystrophy. And in this third lecture, mini lecture, we are going to apply all we knew to find out how we could make the diagnosis of muscular dystrophy, particularly Duchenne, or variants of it on a muscle biopsy. I would like to, I have done it throughout the lectures by noting the pictures from the references I have used, but I invite you really to go and consult the color atlas of muscle pathology from Cumming, and also the Neuromuscular Disease Center, which is a website, an excellent website where you can focus on variety of the disorders that we discussed during the lectures, and also focus on the normal muscle and its study, and that would be your references if you need it. And of course, you're welcome to email me if you have any questions. This time we are going to use the same parameters to see what is present in Duchenne muscular dystrophy and what is not, or to what extent you can find them in Duchenne. First, let's just have a very quick talk about dystrophin itself, because that's basically what is lacking in patients who are suffering from Duchenne muscular dystrophy. They do not have dystrophin in their skeletal muscle. Dystrophin is a part of a very complex protein structure that is combined part of the membrane of the skeletal muscle, and also has with extension, but for some of these proteins within the cytoplasm, with connections to cytoskeletal and sarcomeric structure of the myofiber. So you can imagine that when you're looking at this graphic, that this complex structure, when there's one component that is missing, there's a series of components that are in direct or indirect relation with that component would be also malfunctioning. In this mini lecture, we are going to talk about patients who lack the dystrophin protein. One thing about the study of the dystrophies, and of course any of these proteins have been associated with the type of the clinical muscular dystrophy that has been described, and they can be checked genetically, or they can be also suspected clinically by the presentation they have. Some of these, they are available to testing on skeletal muscle biopsies, but unfortunately we do not have the nature of these proteins that's so fragile, and the place that they have in the membrane or in the cytoplasm is such that we do not have really possibility of testing them at clinical level on every single muscle biopsy. So it's a combination really of the clinical examination of the patient. Nowadays, advanced genetic studies and also pathology on the skeletal muscle that would give the diagnosis. I would like to make mention to you, because as a person in rather patient care and clinical side of the story, that not every single test that is possible in a research lab is possible in a clinical lab. Clinical labs, they have to follow a very different subset of rules and regulations, and use the testing that researchers they have developed, and they have been validated by different measures and different people and different instances to be able to use it as a valid reference for the patients. So even if you come across laboratories that have antibodies, that do different type of sophisticated testing, whether by immunoblotting or immunohistochemistry, they're not necessarily all available in a clinical lab, unfortunately. We would be waiting for you guys to graduate and make them available for us. Let's just remember and look at the normal skeletal muscle biopsy, because that's again the one picture every single day I go to in my mind to make the diagnosis on the muscle biopsy that I examine every day. This obviously, we have our perimysium and our endomysium. You can see the scar tissue. There is no scar tissue. Basically, there is relative minimal collagen or fibrous tissue in there. There is no fat. There is no cellular component, for instance. There is no inflammation or anything in there. We have our polygonal myofibers that are distributed within a range of variation in size. The nuclei are on the side. There are some fibers that can have internal nucleation, but their numbers should be very, very low, particularly in adults. And you can see that the size is not necessarily has a topography in distribution in the fascicle. You don't have small ones on the side and big ones in the center. There is a kind of a uniform distribution. The vessels are understated. You do not have too much of reactivity in the vessels. And when we are focusing on the cytoplasm, any of these myofibers, they do not show any inclusions in them, and they do not show really irregularities in them. So this is exactly what we are going to look in our mind when we are looking at a muscle biopsy that is abnormal. Now, compare this muscle biopsy to the one that we just looked at. What we see is basically a muscle that has lost its normal fascicular architecture. Why is that? For a number of reasons. One, because we do not have healthy myofibers with normal size. So there you have loss of volume. And then because probably this muscle has gone through episodes of degeneration and regeneration, and at some point it has lost the capacity of repopulating the fascicles with normal myofibers. So what installs instead is scar tissue. And the other thing that we see here when looking at this low magnification and very neatly is the fiber size. You can see that many of these fibers, they are very small. And also many of these fibers, they have internal nucleation, not normal. If you focus on the cytoplasm, you would see that in the cytoplasm there are no irregularities really, no indentations or vacuoles or inclusions, but some of these fibers, they seem to be very round rather than being polygonal and intensely eosinophilic or pinkish red compared to the other ones which are, for instance, normal looking. These are called more of a hyalinized fibers. Hyalinized fibers or hypercontracted fibers are fibers that because of the abnormality of membrane, the circulation of the ions, particularly calcium, in and outside of the fiber is disturbed. So these fibers, they have a lot of calcium in them and they are hypercontracted as if though they are in a constant state of cramp. These are the fibers that we would see in subsets of, most likely in many of the muscular dystrophy cases. Somehow they are a sign in a muscle biopsy that may be dealing with a muscular dystrophy. So here you have a muscle biopsy that is showing myofiber atrophy, myofiber size variation beyond what's normally seen in a normal muscle, internal nucleation, hypercontracted fiber, and of course scar tissue. So that is a primary muscle disease, whatever the reason may be, but this is a primary muscle disease. In older days, this kind of biopsy was called dystrophic. It did not mean necessarily in the older reference books that the patient suffered from particular dystrophy, but it was just a pathologic description, and of course now we reserve that term to patients who have, whether we prove or have proven muscular dystrophy. This is a higher magnification of the same muscle biopsy where you can see abnormal myofibers. In this area, I think the fibers were much more abnormal. Not only the size is abnormal, the shape is abnormal, you can see many internal nucleations, some of them have too many of them, and some of these fibers, they are splitting. Again, internal nucleation, you have myofiber size variation beyond what is seen in a normal muscle, and split fibers. Again, these are all signs that we will see in primary muscle diseases. And the increased scar in the endomysium, meaning in between the myofibers, it shows that this muscle has suffered from this disease for a long time and is gradually losing its capacity for regeneration. How we can say, we talked about alkaline phosphatase and acid phosphatase in lecture number 2 about the turnover in the muscle as part of hydrolytic enzymes. How we can say it that there is regeneration and degeneration in a muscle? But morphologically, it is possible. Sometimes it's difficult because there may be the muscle may be so damaged that the only way to look at it really is through those enzyme reactions. But again, those enzyme reactions kind of confirm what we see on standard morphology. And here we have examples of them. We have when you think of a regenerative state is when the machinery is working full blown to replace what's lost. And in a cell means that the DNA is fully active. It means that the nucleus is fully active, it's sending out messages. There's a lot of proteins being made in the cytoplasm, and these cells are starting from basically an immature state, so they are probably smaller. Their DNA is, their nucleus is larger because of the lot of ribosomes and protein in the cytoplasm. Their cytoplasm is much more basophilic looking, at least at the staining, rather than being eosinophilic like a mature myofiber. And here are the state that we see, for instance, in fibers such as this one, or this one, or this one. The nuclei are not well visible, but they are quite large for the state of myofiber, and also you can see the difference in the quality of the cytoplasm. As opposed to that, you can compare these myofibers to the normal ones on the side. Not too normal because they're a little bit abnormal in size, but the cytoplasm seems to be in a normal side. You can see how degenerated look, falling apart look they have. They don't look very healthy. So by looking at standard morphology again, we can have an idea about the degeneration and the regenerative capacity. And then when we use our hydrolytic enzymes of alkaline and acid phosphatase, we can kind of confirm and also have an idea about the intensity of the turnover in the muscle. In a myopathy, it's of course important. We see all the features, histologic, morphologic features that we talked about, and degeneration is a component, at least when the disease is early in its state, in its process. Once that's lost, that's lost. But it kind of gives you an idea about how severe the disease is and how severely the muscle is affected. When it comes to Duchenne muscular dystrophy, we said that the dystrophin, the protein dystrophin, is missing. Now, this can be missing either as a big component, big chunk, or it can be totally missing, or it can be there but not be functional. At a clinical level, again, in a clinical laboratory, we have a way to diagnose that. If a patient has a suspect clinical diagnosis of Duchenne, and we have a skeletal muscle biopsy that shows fiber atrophy, very round hyalinized fibers, scar tissue, internal nucleation, split fibers, and we have the right clinical setting of a young boy who's not able to walk, then we can think about doing immunohistochemistry. Immunohistochemistry is a different set of reaction. Some of you may be familiar with it because you have worked in the lab. And for those of you who are not, very simplistically put, in histochemistry, we are using reagent that would go and basically color the components of a cell. In immunohistochemistry, whether it's done on frozen tissue or paraffin tissue, and for dystrophin we have to use frozen tissue because antibody was developed for frozen tissue. Basically, we are sending antibodies to recognize an antigen. If the protein is there, the antibody is going to make a complex with it, and then we color that complex on top. And if it's there, we're going to have a brown, it happens so in our lab we use that color as a counter stain. The brown coloration, that means that the protein or the component we're looking for is there. Now, if it's missing, we're not going to have that colorimetric reaction that develops in the skeletal muscle biopsy. And that's exactly how we differentiate Duchenne muscular dystrophy in a biopsy from a normal skeletal muscle, or Duchenne muscular dystrophy from other types of muscular dystrophies when studying dystrophin. When we send antibodies to dystrophin, if they're there, they color the muscle, then we know if the patient has an abnormal muscle, it's not Duchenne, or the variants of it. And if it does not have it, then we know that we are on the right track for the diagnosis of Duchenne or variants of it in this patient. The other way of diagnosing the lack or inefficiency of the dystrophin would be by Western blotting. Actually, it's not a bad idea to combine both because, of course, we have the clinic, we have genetic studies, we have our morphology to help us, and then we have immunohistochemistry. In immunohistochemistry, I tell you, in those variants that the protein dystrophin is present only at the weak state, it still can decorate the fibers and we may miss the diagnosis. But if we do the Western blotting to quantify, and if we do the genetic studies to make sure that the mutation that we've been looking for is there, then combined together we can make diagnosis in variants that are not as typical and classic presentation, at least in pathology, as the other ones. We are going to back to this case study that we started our first lecture with. By now, you should be able actually to look at the muscle biopsy from this patient and have an opinion about it. It doesn't necessarily mean that you have to make the particular diagnosis, but you can question yourself. Am I seeing what I've been taught throughout the lectures? We have a 3-year-old male, a good setting for a Duchenne, with developmental delay, mild cognitive impairment, and proximal muscle weakness. The CK was elevated in the serum, and the brain MRI, because of the neurologic manifestations, and CSF by lumbar puncture were normal. But CK was really, really high. What that means is that either there is leakage of the CK from the skeletal muscle, that's really high for just leakage, or active degeneration of these myofibers that are breaking down and liberating the enzymes in the bloodstream. A muscle biopsy was done, and here what we see in the skeletal muscle biopsy of this 3-year-old boy. Now you have to know that when biopsies are coming from kids, we have to have an idea that their muscle biopsy may not necessarily by size be like an adult, so we have to adjust our eyes, but still by adjusting our eyes to the size of the myofiber we should be seeing in this in a 3-year-old, and they're quite good looking myofibers as well compared to adult, not as big but not very, very small. This muscle biopsy shows myofibers that are very small. So in your examination, using what we said so far, what we're seeing again and again, time and again, comparing to the normal, we have increased connective scar tissue in the perimysium surrounding the fascicles, and of course in the endomysium around the individual myofibers. You see that the myofibers are very small, I don't have to point it, and the arrows point to hyalinized or hypercontracted fibers. Many of these fibers, they have internal nucleation, and maybe here and there we can see split fibers, maybe not at this magnification. But if you focus on areas that are looking a little bit bluish with a lot of cellularity to them, these are basically the areas that the fibers have degenerated, and possibly the cleanup crew or the regenerative crew are there to do their job. In some areas even we can see dead myofibers, because you can see there's a myofiber there but it's not really coloring well with the pink. So again, by all standards, this is a dystrophic muscle, at least by pathologic description. But you can call it myopathy, you can call it active because we see areas of degeneration, and you can call it chronic because there is scar tissue. We know that's been going on for some time. Modified Gomori trichome usually shows better the scar tissue, the intensity of it, tells us how chronic this disease is, and also the degenerating fibers, because they kind of color differently from the normal fibers. You can spot them very nicely. Shows an intensity of the inflammation because macrophages, they look purple on this. And also if there are any irregularities in the cytoplasm, we would see too. We're not expecting any in the Duchenne muscular dystrophy. For instance, if the sarcomeres were falling apart, that would be a different thing. If there were vacuoles in the myofibers in another set of disease, that the Gomori would have a different look to it. But here very nicely we see just that the cytoplasm is not so bad, except for the fibers that are hyalinized, of course. higher magnification of the same skeletal muscle biopsy or from other areas that are kind of a little better preserved. We have a kind of an attempt to split fiber here. You can see some people, they may not really buy it, but I think it's there. We have internal nucleation. We have areas of regeneration and degeneration. And again, here you're talking about a primary muscle disease. Myophagocytosis is something that probably you're hearing first time throughout the lecture. I'm not sure if I mentioned it before. But myophagocytosis refers to the fact that when the myofiber is dead, the cleanup crew is going to come and eat it up. And phagocytosis, that's what it means, right? Myo, muscle, phagocytosis, eating. More examples of degenerating fibers. Now, let's just say that degenerating fibers, they fall apart and eventually they are cleared up. And then sometimes, occasionally, the fibers, they would just die in place. They get infarcted. And these are necrotic fibers. Compare the cytoplasm of this fiber to a normal myofiber. You can see very clearly that there is nothing much left in the cytoplasm here. Everything is like basically dead, whereas this one is healthy and eosinophilic. The necrotic fiber secondarily is surrounded by the macrophages. The myophagocytosis happens, and this is very neatly seen in acid phosphatase. Again, the degree of degeneration in the muscle biopsy will give us an idea about the intensity and how fast disease is progressing. Here we have examples of regeneration. A lot of these processes, unfortunately, they do regenerate a little bit in the beginning, but then they fall behind. They degenerate much faster, much more than they are able to recreate or repopulate the muscle. Here you have again areas of the muscle biopsy where you have a lot of fibrosis, of course smaller fibers, but then there are fibers also that are very basophilic, bluish looking, but one single nucleus that is very active and plump, and these are probably the regenerating fibers. These are the ones that I mentioned that in alkaline phosphatase. Also, if it's not evident on basic morphology, we can go and look for them on alkaline phosphatase. Not everything that is reacting black in alkaline phosphatase is regenerating fiber, but some of these by morphology comparison, we can tell that there is a little bit of regeneration still going on. But unfortunately, as you saw, the degeneration was much faster. Dystrophin immunohistochemistry was done. Every single time we do an immunohistochemistry in a clinical laboratory, we have to have a normal control for it to make sure that the technique has worked. So in a normal muscle, we obviously detect the dystrophin as a brown coloration of the membrane, so it's normally there. Whereas in this particular patient, the protein is missing from the myofibers, so you don't see that brown coloration surrounding the myofibers. Now, the way we study the dystrophin, of course, it has multiple components. There is the C-terminus and terminal. There's rod domain. Each have different antibodies, and we do 3 sets of study. Sometimes most of the time 1 or 2 components are missing. So based on our observation of increased fibrosis, abnormal fascicular architecture, those were definitely distorted fascicles, central nucleation, myofiber atrophy, and fiber size variation, degeneration and myophagocytosis, and particularly lack of dystrophin in this child, we can ascertain the diagnosis of Duchenne muscular dystrophy. You can see that again by using different stains, different reactions, and complementing it with immunohistochemistry, we would confirm the clinical diagnosis. Again, nowadays we have the luxury and the privilege of having genetic studies, and those, of course, skeletal muscle pathologies complementary, and then they basically not only confirm the diagnosis, but sometimes they show also the complexity of the disease. Things of different nature, they may look the same in pathology, and patients with the same mutation may have different look to their pathology, so it's an ongoing study. we are going to look to another case. Now, this time we're talking about an adult. This is a 29-year-old male, which for a very long time since he was a child had, as long as he remembers, has lower extremity weakness. Sometimes these patients, they come to you and they mention that I have never been able to participate in school activities, sport activities, or I have been sick every time I did an exercise and I had to stop, but they never really went. And sometimes these patients, they may also have a family history of muscle disease, but not always, obviously. But all of these are helpful to make the diagnosis. Now the patient is wheelchair bound. Because we're talking about muscle, the simplest, the most simple thing to do is to measure the CK level in the blood. And in this patient, it's at 3,000, which is 10 times more of the highest level of the normal. Also, another way of looking into the health of the skeletal muscle is to do the electrodiagnostic study. It's kind of a not very fun study, but it's very, very valuable. It's not fun for the patient because these are like acupuncture-like needles that they put on the muscles. They register and record their electrical activity, and they want to see if the muscle is sending out normal waves or not, basically. And if not, what type it is. Is it because the nerve is not functioning well, or is it the muscle itself is not functioning well? So this patient here we have with muscle weakness, cannot really walk anymore, but it's been going on for a very, very long time, and the CK is moderately elevated. On the skeletal muscle biopsy, again, remember the normal skeletal muscle biopsy. From top to bottom, the first thing to look at is the connective tissue surrounding these fascicles. Increased, a lot of scar tissue, not only in the the connective tissue where the muscle is embedded, but also the endomysium where the myofibers are supposed to be in contact together. You see fatty infiltration in some areas. The areas that are falling apart, kind of, it's fat because fat doesn't cut very well on the frozen section. And also, you know, you can see the areas of cellularity which signals degeneration. Myofiber size variation. This is a very low power view for you to see how the fascicles are kind of distorted and not as sharp and stretched as they should be. So we saw the scar tissue and abnormal fascicular architecture. Going down, this is again, you know, we see the scar tissue. We see the areas of the degeneration. Some of these were fibers that were cleared out. Some fibers are degenerating. Some fibers are going through the myophagocytosis. So we have regeneration and degeneration going on. Degeneration not so much, quite frankly. I'm not sure. Maybe a couple of these fibers, they are a little bit basophilic, but actively degenerating for sure. Myofiber size variation is not normal. Some of them are very tiny and some of them are a little bit bigger. And there are obviously fiber atrophy in this muscle. This is just to signal degenerative changes again. These fibers that are singly falling apart. Another necrotic fiber, this fiber just died in place. And sometimes when there is no regeneration happening, there is a hollow space in place of the fiber, and in pathology jargon we call it ghost fibers. The more you see them, the worse it's for the patient. Notice that many of these fibers are small and they have an internal nucleation. Maybe this fiber has a very plump nucleus. Maybe this is an attempt to regeneration. In this patient, we did the immunohistochemistry for dystrophin. One of the components, I'm sure that I am representing here the one that came out abnormal. Normal control to make sure the technique worked on this side. And you can see that the myofibers are surrounded by brown colorimetric, so the protein is there. However, on this muscle from the patient, you can see that there are many fibers that lack the protein. And some of them, there is an attempt to have a little bit of coloration of the protein. This is what I was telling you about, that when the reaction is weak, it's very difficult to ascertain that the protein is actually, the residual protein is functional or not. What we can say is that dystrophin is not normal in this patient. However, I think the clinical presentation are very slowly progressive and over the many, many years, and the fact that there is still a little bit of muscle left in this patient, the diagnosis on this patient would be rather a variant of the dystrophinopathy, which is a little, leaves a little time for the patients to remain independent and use their muscles and their legs, and are able to walk, and then they lose the capacity to use their muscles. This is Becker muscular dystrophy. Again, these are always corroborated with genetic studies when available to the patients and the clinicians, and the follow-up, obviously, of these patients to see how they are doing. Some of these patients, they may have another biopsy later on, but generally it's only if they show another atypical clinical presentation. They generally don't need a second biopsy. Last, I would like to look at this muscle. This is a patient that basically is very weak and wheelchair bound. The muscle that is biopsied clinically was very, 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 very damaged. You could see clinically that this muscle had no tone, was very small, very atrophic, basically melted down. And exactly on pathology, this is what we're seeing, what we said about the primary muscle disease, what is happening to the myofibers. The myofibers, they get, due to lack of proteins, some components, dysfunction of their organelles, they would lose their normal function. They cannot maintain their state of health. They degenerate and they are eaten up and taken away. And because over time muscle loses its regenerative capacity, instead of having myofibers that repopulate the fascicles, you will have more and more and more of scar tissue. And that is how we diagnose an end-stage muscle. End-stage muscle is not a very good muscle biopsy to read, because a lot of time there is so much of inflammation and scar tissue in it that the primary pathology is very difficult to detect in it. So the clinicians generally, they do not biopsy the weakest muscle, or the most affected one clinically. They try to choose a muscle that is weak, sick, but not totally lost, so we would be able to see the disease in action. Here you have what we just said about the scar tissue, abnormal vesicular architecture, absence of significant degeneration, which would define the end-stage muscle. Here are the references. Again, I invite you to consult them, and I thank you for your attention.